While seeing your next patient in the emergency department, somebody runs in and says that a burn patient showed up, and you wonder, how can I best take care of this patient? Do I need to transfer them or something?
And EMS brings in a patient from the nursing home who is altered with hyperglycemia. You wonder, could this be DKA or HHS? And how do I differentiate between the two?
In this episode of Critical Decisions in Emergency Medicine, we will talk about managing thermal burns, how to resuscitate the patients, and how to appropriately disposition them.
We will also discuss management of diabetic ketoacidosis and hyperosmolar hyperglycemic states.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices in Florida and all over the world.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the October 2025 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features such as the critical procedure, critical image, and lots of pros from our drug and tox boxes.
So for our first lesson of today, firefighter managing thermal burns. Thank you to Dr. Taylor Lindquist and Bennett Myers for writing this article.
Let's start with what we are talking about here. What are thermal burns exactly?
So thermal burns basically are when an external heat source disrupts layers of tissue and causes damage. The obvious one is direct or indirect exposure to flame, like flash or flame burns, or exposure to high-temperature liquids, just as called burns, and also direct contact with high-temperature objects, which we call contact burns. All of those are treated the same way and are considered thermal burns.
That makes sense. So what affects the severity of these burns?
Well, the severity of the initial insult is dictated by several factors, such as the patient's characteristics, the heat source for the burn, the patient's contact time with the heat source, and the anatomic location of the burn, as the skin thickness differs in different locations of the body.
Okay. Is there a way to describe this severity?
Well, historically, thermal burns have been described by varying degrees. We would say, well, it's 1st degree, 2nd degree, 3rd degree, 4th degree. However, the American Burn Association and other groups have standardized the classification of the burns by depth and thickness. So now they're called superficial, partial thickness, superficial and deep, and full thickness. And there's a great table in the article that explains the difference in the layers damaged, the clinical presentation, and how long they take to heal. Obviously, those are going from the less severe to the more severe. Another important element of describing a burn is the body surface area. The most common way to do that is the rule of 9s, and Figure 1 depicts that clearly for adults and children. The cheating way to do this is remember that the patient's palm is 1% of their total body surface area.
That's true. Definitely use the patient's palm and not your palm.
I do have large hands.
What about patients who require intubation? When should we consider these?
Well, burn patients should be approached the same way we think of when we approach trauma patients. So, the same way ATLS says, ABCs. We should assess the airway the same way, and if there's any sign of airway compromise, we should go ahead and proceed with intubation using RSI. A couple of pointers is that in delayed presentations, so longer than 24 hours after the burn itself, we should avoid succinylcholine for the concerns of hyperkalemia, as well as consider higher doses of paralytics given the hypermetabolic state in that delayed stage after a burn. It's important to remember that a difficult airway due to airway edema should be anticipated, and we need to prepare multiple options, such as having a bougie, a smaller tube, and be prepared for a surgical airway as well if needed.
Great reminders for sure. What about patients without these hard signs of airway compromise? Any particular considerations in taking care of these patients?
Well, even if the patient does not have any obvious signs of airway compromise, we should evaluate them with video laryngoscopy or nasopharyngoscopy to look for edema, extensive erythema, or soot in their airway. And this may allow us to avoid unnecessary intubation. Interestingly, there is a study mentioned in this article that says that 30 to 50% of patients who end up presenting at a burn center, which obviously would be considered sicker patients, have had an unnecessary intubation that could have been avoided. That's 1 in 3. That's a lot.
That is a lot. Wow. Certainly, I think burn patients make us all comfortable, and these are definitely challenging to tease out. Any particular consideration when we are providing the mechanical ventilation in these burn patients?
Well, we need to ventilate them with 100% humidified oxygen to help temporarily clear the carbon monoxide, which is a little different from our mentality that we don't need to hyperoxygenate patients to avoid hyperoxia. Well, this is a slightly different population, and you do want to go with that 100% because of that likely carbon monoxide exposure. In these patients as well, we need to continue aggressive post-intubation analgesia because they have a very painful condition. Another important thing is that we need to keep checking the endotracheal tube placement because edema resulting from aggressive fluid resuscitation can actually displace the tube. And in patients with burns to their chest and difficulty with ventilation, we need to think of compartment syndrome of the chest.
Very good points as well. What are some key elements in the evaluation or workup of patients with these thermal burns?
Well, as we mentioned earlier, we would approach them the same way we approach major trauma. ABCs, 2 large IVs, monitors, resuscitation, primary survey, secondary survey. It's important to remember that adequate pain control is important to help with the physical examination. We need to check peripheral pulses, especially distal to the burn itself, and we need to remove clothes and jewelry and do a log roll. As part of the assessment, something that's unique here other than the ATLS for typical traumas, is that we need to calculate the total body surface area to figure out how much total fluid is needed, as well as figure out if we need to escalate care with transfers or calling consults and so on.
Gotcha. Now, what about an escharotomy? When should we consider this?
So patients who have compartment syndrome secondary to thermal burns are going to need one. And that's usually going to be in patients who have full thickness burns and that are circumferential. And it's important to remember that this can be quite often a delayed presentation because of the edema and the fluid shift, especially with resuscitation. In these patients, we would call surgery, depending on who takes care of this type of injury at your place. But if surgery is not available or is delayed in getting to your patient, this is 100% an emergency department procedure and under our purview to take care of patients. The idea is basically to incise through that burned tissue down to the subcutaneous fat layer to release the eschar's constrictive effects and restore the circulation. And the exact pathway of the incision varies based on the anatomic location. And the idea is that you go through the entire length of the burn and a few centimeters into each direction into the healthy skin. You usually start with the mid-lateral or mid-medial aspect of the limb, from proximal to distal, and then if the patient's circulation does not improve, then you go for that opposing incision. With hands and feet, you incise the dorsal surface, and with the chest, it's a little bit more of a complex configuration with bilateral mid-axillary lines from the 2nd to the 12th rib, and then 2 transverse incisions in the upper chest and upper abdomen, and those are going to bleed, but not life-threatening. But keep that in mind. There's a great figure in the article that shows these incisions and is a great visual reminder.
Definitely check out the figure for these locations of the incisions. What about recommendations for fluid resuscitation with patients with these burns?
So this article has a ton of pearls, and this was one of them for me. Now, we all know that patients do require fluid resuscitation. But according to the American Burn Association consensus of 2023, if the total body surface area included is 20% or more, then that's when you go with IV fluids. Smaller than that, oral resuscitation may be appropriate if there are no concerns for oral consumption. And then the other reminder is that all the numbers are not rigid definitions or rigid numbers that tell us of how much fluids we need to give a patient, but we need to continually titrate it according to the patient's clinical response. I learned the Parkland formula, which is 4 mLs times the percentage of total body surface area times the weight in kilos. However, there's something called the modified Brook-Burn formula that uses 2 mLs instead of that 4 mLs, and it is actually the one that's recommended by the American Burn Association, because then you are more likely to avoid fluid overload and yet maintain adequate resuscitation. The first half of the fluid should be administered over the first 8 hours, and the second half over the following 16 hours. And of course, we need to continue to monitor the urine output and make sure that it is adequate at 0.5 mLs per kilo per hour. What I found also quite interesting is that in addition to crystalloids, which is what we usually think of for resuscitation, There are a few other things that we can think of outside of the immediate resuscitation, especially when people are boarding longer in our EDs or waiting there for the transfer. One is albumin, which is intended to lower overall resuscitation volume and increase urine output. And that may be used in patients who are deteriorating in the first 24 hours despite adequate volume resuscitation with a crystalloid. FFP is not recommended, and neither is high-dose ascorbic acid. I thought it was a little odd that we're talking about vitamin C in an actual real medical question here. But apparently, vitamin C promotes diuresis. But the issue here is that if you're promoting diuresis, then you're losing your marker of true urine output, and you may actually worsen renal function due to oxalate nephropathy. Another interesting pearl is that if the patient has refractory shock and hypotension despite adequate fluid resuscitation, we should obviously give them inotropes. That's not the pearl here, but it's that they have no consensus on which one to give, whether it's norepi or vasopressin, because that continues to be a debate.
Very interesting. The modified preferred formula is also new to me, so something I'll take away from this lesson. Now, what about general wound care? Obviously, they have burns to their skins. How do we care for the wounds themselves?
Well, that's a great question. And I think that's something that's helpful for everybody, because that's not just your critical cases, that's your urgent care cases too. Now, blister debridement is like the $1,000,000 question. And the evidence is mixed to weak in support of the blister debridement because it is there, it's a barrier, it protects it. But also, the blisters contain harmful cytokines that can actually impair or worsen wound healing. And then the tricky part here is that with the blisters, you don't really know the true size of the burn, and you may under-recognize that. Now, the evidence is a little bit stronger for blisters that are extremely tense and painful, those that cross joints, or whose location can restrict function, in actually saying that you need to aspirate it or debride it. The other ones, again, it's a question mark over there. If the patient is going to be transferred elsewhere, you should probably leave that for the transferring facility so they don't have to do this twice and undergo this discomfort twice. In that case, just wrap the wounds in moist saline-soaked bandages and sterile drapes and then transfer them. If the patient is staying with you or that transferring facility requests that you take care of that, then the first thing you need to do is make sure the patient has adequate analgesia, and then get gauze, soak it in diluted antiseptic or mild soap with water, and no scrubbing. Just use the soaked gauze to unroof the blister by applying swift, direct, downward pressure while slightly cupping their hand over the blister. Another thing that you can do is to use an 18-gauge needle to actually aspirate the fluid from the blister. Now, outside of the question of whether you want to de-roof or aspirate blisters, you still gotta take care of the other burns, especially if there is no blister on top of it. Now, if it is a superficial burn, then over-the-counter emollients or petroleum jelly can be applied intermittently throughout the day and no dressing. You can even actually add topical diclofenac gel directly on it to improve the pain and discomfort, and there's no safety concerns there. Now, for superficial partial thickness burns, then you can use antimicrobial treatments such as bacitracin or mupirocin or medicated xeriform gauze. A pearl here is that you can apply the antibiotic ointment to the gauze or the dressing bandage rather than the wound itself to minimize discomfort. Now, deep partial thickness burns, those you would treat them with long-acting dressings such as silver-containing antimicrobial dressings, which can be kept in place for 5 to 7 days. Remember that you should not be using silver sulfadiazine in patients who have sulfa allergies or those with G6PD deficiencies. Now, of course, full-thickness burns are ones that require surgical intervention and are not ones that we should primarily care for in the emergency department.
That's great. A lot of pearls there as well. You mentioned about patients being transferred to burn centers. How do we differentiate those who need to be transferred and those who we can discharge from the ED?
Well, patients with burns involving 10% or more of their total surface body area should be transferred to a burn center. Of course, burns in certain anatomic locations also require transfer because of concerns for scarring and contractures, such as hand, feet, major joints, face, genitalia, perineal regions, full thickness burns, and then, of course, patients who have lots of comorbidities where we have concerns of healing, and then social situations that are quite complex may be considered for transfer as well. In patients who have impending airway compromise or have major burns, so 20% or more of total body surface area, those are the ones that we would want to consider intubating prior to transfer.
Well, thank you, Danya, for taking us through this lesson. There's a lot of pearls in here for a topic that we may not discuss that often. It's good to remind ourselves that the nomenclature for thermal burns have changed as opposed to previously named first, second, third degree, etc. And now it's referred to as superficial partial thickness and full thickness, and definitely can refer to the lesson for differences in the layers of the skin that are being affected. We often do think about airway because it's, of course, ABCs in any of the patients we take care of. And so if they do have signs of airway compromise, such as edema, erythema, soot in the airway, then we do want to, of course, intubate these patients while anticipating for the potential difficulty, such as prepping multiple devices, including a bougie or a smaller tube, and even prepared for a cricothyrotomy if needed. When you do intubate one of these patients and ventilate them, a few other considerations would be to ventilate them with 100% oxygen to try and help clear the carbon monoxide, and of course, providing adequate analgesia, as well as the placement of your tube that could be compromised from potential developing airway edema. Now, in terms of fluid resuscitation, we previously may have learned in the years past the Parkland formula, but the lesson shared with us a newer approach to fluid resuscitation, which is the modified Brook-Burn formula, where we actually use only 2 mLs per percent total body surface area affected times the patient's weight to avoid fluid overload that can often happen in these patients. The same approach, though, in giving half of the fluid over the first 8 hours and the second half over the remaining 16 hours is done. And as you would in any sort of resuscitation, you can monitor an output as a way to guide further resuscitation. A few other considerations for these patients would be if their burns are quite extensive, such as circumferential. These patients can be at risk for compartment syndrome, and we may have to actually consider performing escharotomy, which in the lesson, there's really great diagrams that help us think about where to actually perform these incisions. In general, what you're trying to do is to incise through the entire length of the burn a few centimeters into the healthy skin, and most importantly, down to the subcutaneous fat layer to release that eschar's constrictive effects on the perfusion of the tissue. The lesson also provides some really good pearls on general wound care, which is probably the bulk of what we often provide in the ED in the range of the burn injuries that we may see. And so if it is superficial burn, then you're talking about utilizing maybe over-the-counter emollients or petroleum jelly, as well as maybe even topical diclofenac, which can help with analgesia. The debate often over whether or not to unroof blisters. This is still a debate, but you can consider it for really tense and painful type of blisters that crosses joints or other locations that restrict function. And you can do it in 2 ways, whether it is with a downward pressure or use an 18-gauge needle to aspirate the fluid. For partial thickness burns, then you're talking about more specialized dressings, such as silver-containing antimicrobial dressings to help with wound healing in that effect. And then finally, it's always good to remember when we do actually need to transfer patients to a burn center. And so generally, we're talking about patients with burns that involve more than 10% of their total surface body area, patients with the full thickness burns because they're going to need some sort of a surgical intervention, those with inhalational injuries, as well as those patients who may have comorbidities or complex social situations. So thank you to our authors for writing this wonderful lesson.
Thank you indeed. Our ECG this month is about a syncope in a young man who presents to the emergency department feeling still dizzy with some palpitations after the episode. And of course, an ECG is done, and it shows a very rapid, irregular rhythm with wide QRS complexes and beat-to-beat variation in the appearance of the QRS complex. The article walks you through step-by-step thinking of how to get to the diagnosis. Simply, it can be one of 4 things. It's either AFib with a bundle branch block, multifocal atrial tachycardia with a bundle branch block, WPW-related AFib, or polymorphic VTAC. And it's not the AFib or the MAT with bundle branch block because the rate is much too rapid for that. Polymorphic VTAC would not have such a variable look of that tachycardia complexes. So the only thing left on the table really is WPW. And the reason we need to think of that, especially in somebody who has an extremely rapid rate greater than 220, is because, as you remember, the issue with WPW, we do have the accessory pathways. And the management of these patients would differ because you should not really be giving them any AV nodal blocking agents, such as beta blockers, calcium channel blockers, adenosine, or amiodarone, which you would give in a typical AFib. And therefore, the two options you have here are either to administer procainamide or do an electrical cardioversion. And that is what was done in this patient, and he did well. And then the article does show the ECG that they got after the cardioversion that shows the classic triad of WPW, which is your shortened PR, delta wave, and minimally widened QRS complex. So definitely a great reminder of something that we don't see often, but we get asked about on the boards all the time. And more importantly, one, if mismanaged, can lead to serious problems. So take a look.
Our clinical pediatrics this month is a preteen boy who presented 3 days ago with left hip pain. And this is after exposure to somebody with an upper respiratory infection. Now, he did get some ketorolac and his pain improved, so he was discharged with a presumed diagnosis of transient synovitis. But unfortunately, his pain did get worse, and so he returned to the ED and now unable to ambulate. And you find that he has limited range of motion in all directions of his left hip, pain with log rolling, and unable to bear weight at all. You end up getting an MRI, ultimately, because you have a very super efficient ED. And this shows that there is a left hip effusion with synovial thickening and hyperenhancement consistent with synovitis, and there's surrounding soft tissue inflammation that is concerning for septic arthritis.
Well, this case highlights the fact that one, MRIs do exist in emergency departments sometimes, but more importantly is that we should always maintain a high clinical suspicion for septic arthritis. And one clinical clue that this is not just good old transient synovitis is to make sure that the patient's able to ambulate during our examination to thoroughly assess for any altered gait, limping, or signs of pain, because that is an important part of the clinical presentation of a septic hip. Additional things could be a temperature greater than 38.5, an elevated CRP more than 20, increased white blood cell count above 12, and the constellation of these signs and symptoms offers a predictive probability of septic arthritis around 87%. Cocker's criteria uses an ESR instead of greater than 40, but also the idea is that those are some ways for us to systematically approach these complaints. We need to remember that ESR by itself is not the best inflammatory markers because its predictive ability can be as low as 53%, whereas CRP tends to do a little bit better, but it does not start to increase until 24 to 48 hours after the onset of infection. However, reality is that CRP, ESR are not great. Our most sensitive lab finding is a joint aspirate leukocytosis. Everything else is just there to support our decisions. An X-ray may reveal erosions within the bone, and at that point, that would concern us about osteomyelitis. If we see a joint effusion, then we need to think a little bit more of septic arthritis, and an ultrasound can help us do that. But at the end, MRI is the most sensitive imaging modality. Now, once a diagnosis is made, the question is, should we start antibiotics or wait for that joint aspiration or washout? Now, obviously, if the patient is septic, then we should go ahead and not wait for anything and start the antibiotics immediately. However, if there's no signs of sepsis, we may want to consider holding off on the antibiotics until after the aspiration or washout, because literature from the adult population shows that antibiotic administration can decrease the rate of culture positivity and therefore can make it more challenging to figure out the long-term treatment. But of course, with sepsis, we should go ahead and treat, and ceftriaxone and vancomycin are reasonable options.
Definitely need to have a high index of suspicion and tap that joint.
For our LLSA literature review, we have the albuterol-budesonide rescue inhalation for asthma. And it's an article by Pappy et al. That was published in New England Journal in 2022.
This is a great article that reviews, like the title mentioned, albuterol-budesonide as a kind of a combo inhalation treatment for asthma exacerbation. And we know that often when patients are presenting with acute asthma exacerbations, we are using short-acting beta agonists in the form of albuterol to get symptomatic relief. But unfortunately, this does not really address the underlying inflammatory physiology of asthma or prevent future asthma exacerbations. So there was a trial that was done, Mandela trial, that looked at the efficacy and safety of this combination treatment as a rescue therapy. And so the combination treatment did include a glucocorticoid, in this case budesonide, and a bronchodilator, in this case albuterol, in the form of a fixed-dose rescue inhaler. This double-blind randomized trial was done at close to 300 sites throughout the world and looked at patients older than 4 years who are presenting with a severe asthma exacerbation. Adults and adolescents were randomized in a 1:1:1 ratio with a high-dose group and a low-dose group, as well as an albuterol alone group, whereas pediatric patients between 4 and 11 years were randomized just to the low-dose or the albuterol group. Ultimately, they included more than 5,000 patients, and they found that there was a decrease in the risk of severe asthma exacerbation in the patients who received a high-dose combination of albuterol and budesonide when compared to albuterol alone. And this was a 26% decrease, so quite dramatic. There was no difference in terms of any sort of adverse outcomes. And so really this study suggests that we should replace just using short-acting bronchodilators, in this case of albuterol, with instead a combination of inhaled glucocorticoids, such as budesonide, with albuterol as rescue treatments. Moving on to our critical procedure this month, it is a partial nail removal, which is important to know.
If you do have an ingrown nail and you have significant irritation or infection associated with that, this becomes a pretty important procedure. Now, of course, if you are not able to do it, then it's going to be a poor cosmetic outcome, or the infection may worsen because now you have a retained foreign body. But if you can do it, then you can avoid having the patient need to follow up with a specialist, which can be quite difficult sometimes.
Very true.
So how are we going to do that, Wendy?
All right. It's pretty intuitive, but a few things to consider. You can certainly provide the patient with a digital block for analgesia, and you can also use a digital tourniquet to reduce the bleeding associated with this. And for the actual nail removal part, you can use scissors to advance and separate the nail from the nail bed, then cut the nail lengthwise to separate the nail from the nail bed. Potentially, you're also going to need to incise any surrounding tissue if the outer aspect of the nail is trapped in that. And then you would just grasp the nail that you had separated and try and rotate to remove it. If you've successfully done that, you would want to dress the wound with antibiotic ointment in a non-adherent dressing.
Definitely simple and worth a try, given that it would make some of our patients' lives a lot easier. So our critical cases in ortho and trauma this month is a case of a 55-year-old man who is presenting after a fall.
Yes, he actually fell off a 10-foot ladder and landed on both feet and had immediate pain in his feet as well as his left hip. So when you evaluate him, though, you do find a mid-femoral deformity as well as tenderness of both heels. So you get some x-rays and you find that he has some calcaneal fractures.
The x-rays do show calcaneal fractures, and these are 2% of all fractures. They're actually the most common type of tarsal bone fracture. They usually happen with high energy mechanisms, and that's why when we see them, we have to look for concomitant injuries. Patients are going to have significant pain at their heels, and they may have something called the Mondor sign, which is bruising that extends to the plantar surface of the foot, and it's pathognomonic for calcaneal fractures. In order for us to see that, we have to order the correct X-ray series, which is lateral, axial, and oblique views of the foot. Occult fractures can be missed if we don't actually calculate the Bowler angle, which is better seen than described. Basically, you draw two lines, one from the highest point of the anterior process of the calcaneus to the highest point of the posterior articular facet. And then the other one is from the highest point of the posterior articular facet to the highest point of the calcaneal tuberosity. Again, those words made no sense. Just take a look at the figure. Now, these lines should intersect and form an angle between 20 and 40 degrees. If it's less than that, then that's highly suggestive of a calcaneal fracture.
Now, don't forget that these patients who have calcaneal fractures often are involved in a high energy mechanism of injury, so you should do a full trauma evaluation and pay special attention to the lumbar spine because of the axial load that is applied throughout the body. And in terms of management of the calcaneal fracture, you want to apply a posterior splint with the foot in a neutral to a slightly plantar flexed position. Certain populations at higher risk of complications are older patients, are immunocompromised patients, patients who smoke, and patients with peripheral vascular disease. Another specific type of calcaneal fracture we have to think about is what's called a tongue-type fracture pattern, where the Achilles tendon pulls on the posterior calcaneus, and that pulls out a portion of the calcaneus superiorly and posteriorly. And this particular fracture pattern is more likely to cause soft tissue damage and skin breakdown, potentially leading to an open fracture. If you do find this, you want to get an immediate orthopedic evaluation.
Great tips. Now, our critical image this month is an 85-year-old man who's coming in with left-sided weakness for the past 2 weeks. The left arm and leg have a 3 out of 5 strength. Now, his head CT reveals an area of vasogenic edema and mass effect. And a CT of his chest, abdomen, pelvis shows a pulmonary embolism. So because of the PE, he is treated with heparin. And 2 hours later, the patient becomes somnolent and a repeat non-con head CT is performed. Wendy, your face tells it all. You totally know where this is going, don't you?
Yeah, that repeat head CT is concerning because now you see a hyperdensity in that area of the mass you saw before, but you're worried about hemorrhage because you just started the patient on anticoagulation. And I think the challenge in this part is trying to figure out, is this hemorrhage or is this maybe something else? And the case is an example of contrasting, where you could have IB contrast that's deposited in the brain tissue after, in this case, the patient having received a CT chest, abdomen, pelvis with IB contrast. And this sometimes can be mistaken as hemorrhage. In the past, it's really hard to distinguish these between hemorrhage and contrast, but now there's additional CT technology that helps us figure it out. One way would be you could measure the Hounsfield units. The other way is what's called a dual energy CT, where you're essentially using 2 different X-ray energies to differentiate between these materials. And so what happens then is on a dual energy CT, you'll be able to differentiate on one scan what looks to be hyperdensity and what goes away because it's actually just contrast. Another option, if you don't have this dual energy CT technology, would be to get an MRI, because with MRI susceptibility sequencing, that can help differentiate between contrast from blood. Or the third option is to observe the patient and get a follow-up PET CT in the traditional method.
Makes sense, and a definitely complex case to manage with a scary CT as a result. Now, our second lesson of this issue is off base: diabetic ketoacidosis and hyperosmolar hyperglycemic state. Thank you to doctors Adam Manners and Samia Faruqi and Prag Mehta for writing this article. Now, we did briefly talk about pediatric DKA and HHS last month, but now this is an entire lesson dedicated for a deep dive into these common and scary conditions. First things first, what causes DKA?
I think what's interesting about DKA is that while the patient is presenting hyperglycemic, it's actually a starvation state that causes the ketone bodies and the metabolic acidosis. And in these patients, they have an absent or a relative deficiency of insulin, and that's what causes a catabolic state, resulting in, again, the hyperglycemia and the ketoacidosis. And as we know, it's often the initial presentation of type 1 diabetes in close to 40% of cases, and often a complication of type 2 diabetes in almost a third of the cases.
So, which patients are at risk for DKA?
The most common precipitants are when they don't have enough insulin, whether it's because of poor access to medication or missing doses, or maybe even because they are having trouble with vomiting and poor PO intake. And then another common precipitant would be an infection. And so all of this then leads to, as we mentioned, this particular imbalance in their glucose metabolism. A special population that we have to think about are pregnant patients because they experience increased insulin resistance during pregnancy, and then they're at risk for starvation because of the fetal caloric needs, and also at risk for dehydration, such as from hyperemesis gravidarum. And so that really puts them at high risk for DKA. And then don't forget about other conditions like trauma, MI, pancreatitis, drug uses. Those often are also associated with DKA as well. A newer precipitating factor for DKA are these SGLT2 inhibitors. As we know, they actually can precipitate euglycemic DKA, which makes diagnosis sometimes challenging. And the reason it does so is that these medications promote diuresis through glucose excretion, and then that can worsen the dehydration and electrolyte use, as well as promote ketogenesis. So all of this then leads to a relative insulin deficiency, causing the keto body formations, while not actually presenting with hyperglycemia because they are excreting their glucose through the urine. So we need to still think about DKA even if patients may present with normal glucose readings.
That's a great pearl. So, how do we diagnose DKA?
Well, these patients are often presenting with abdominal pain, vomiting because of the acidosis and ketonemia. And then they may present with the polyuria, polydipsia, weight loss because of the osmotic diuresis. And they often appear quite ill with hypovolemia presented by their tachycardia. And so when we are evaluating these patients, we often, again, are looking at their glucose level. If it is greater than 200, their acid-base status with a pH of less than 7.3 or bicarb less than 15. And then also, of course, looking at their ANI and gap greater than 12, and then for any positive urine or blood ketones. And so that means you're going to need lab studies, including a basic metabolic panel, a venous blood gas, as well as, of course, a ketone level, whether serum or by urinalysis. As we mentioned, euglycemic DKA can be a subset of patients you take care of. And so having that history of the patient being on SGLT2 inhibitors is important. And again, paying attention to the ANI and gap, not just the glucose level. The article does include a table that outlines the severity grading of DKA that corresponds to the pH level, serum bicarb level, and the ANI and gap as well.
Got it. So let's talk about the management. I know there's fluids and there's insulin, but any pearls that we can focus on?
Absolutely. Definitely, we need to provide a lot of volume resuscitation. We also have to replete electrolytes in a lot of cases, and then really need the insulin to correct the hyperglycemia and acidemia. And don't forget, of course, treating the underlying cause. A lot of these patients come in with a significant water deficit, maybe even up to 7 liters is what the article mentions. And so that's why restoring the patient's intravascular volume with resuscitation really improves overall tissue perfusion, their hemodynamic stability, etc. And so we might start with crystalloids initially 15 to 20 cc's per kilo in the first hour, and then continued resuscitation based on your assessment. We do want to avoid hypotonic solutions because that would decrease the osmolality of the blood too rapidly, which puts the patient at risk for cerebral edema. So generally, we're reaching for normal saline or lactated ringers initially as our resuscitated fluid. Specifically in pediatric patients that we previously mentioned, and just as a reminder here, we want to definitely pay attention on the amount of fluid given and be a bit more judicious than adults because they're at higher risk for the cerebral edema development. Now, I mentioned electrolyte repletion. DKA causes a total body potassium depleted state because of urinary losses. And so it's very, very important to replete the potassium, especially before we provide insulin as a treatment. So if the patient is presenting with a potassium level less than 3.3, you really should not give insulin until you get the potassium repleted. If the patient is presenting with a higher potassium level greater than 5.3, then you could certainly start insulin therapy. Ultimately, as we mentioned, insulin is the definitive treatment for DKA because we need to, of course, halt the production of the ketone bodies. And so we generally are reaching for initial bolus of 0.1 units per kilogram, followed by infusion of 0.1 units per kilogram per hour. You can give a higher rate without a bolus. That's another treatment strategy as well. But you're really looking at the response to the insulin therapy. If you find that the glucose level does not fall by 10% within the first hour, then you should probably also reassess your fluid resuscitation to see if the patient needs both concurrent treatments. Now, we often also encounter that the glucose level does fall, but the patient is still acidotic and so still needs to remain on insulin therapy. And that's when we actually also reach for giving a dextrose-containing fluid to prevent hypoglycemia while we continue to provide insulin therapy to treat the ketoacidosis component. A lot of hospitals all have protocols for this, and so definitely refer to that to be familiar with your threshold generally on when to transition to the dextrose-containing fluids. Once you get a glucose less than 200, a bicarb greater than 18, and a pH greater than 7.3, then you have resolved the DKA part. And that's when we have to think about transitioning to a short and long-acting insulin regimen so that we can transition off of the IV insulin. Now, one important pro is that because IV insulin, of course, has a short half-life, we want to make sure there's overlap between your sub-Q insulin therapies. And so generally, you're giving that sub-Q insulin, long-acting insulin, and waiting 1 to 2 hours after that before you turn off your IV insulin.
So, what are some complications we have to watch out for in these patients?
We mentioned cerebral edema, which can be higher risk in pediatrics, and that generally occurs when there's a rapid osmolarity change. And so that's why we want to pay attention to the fluid choice that we are providing. If you do find that your patient is becoming altered, complains of a headache, then you want to get a head CT to evaluate for the cerebral edema, decrease the rate of your fluid administration, and maybe even administer mannitol in severe cases, even intubate the patient to protect their airway. The other complication we think about is, of course, too much fluid resuscitation and development of ARDS. And so that is also a potential complication. It's tough because you want to resuscitate them, but sometimes you end up on the other end of the spectrum.
Definitely a delicate balance. So let's move on to HHS. How is it different in the diagnosis and management from DKA?
Well, HHS commonly presents with a patient who is altered, and that's because of this increased blood osmolality that occurs. And so these are generally patients with type 2 diabetes and older patients. These patients also present with really high glucose levels, but not too much acidosis because they have some amount of low-level endogenous insulin that prevents the lipolysis process. And so in terms of management, that makes it that fluid resuscitation is the main focus to get the patient certainly resuscitated. If the patient's osmolality is really, really high, like greater than 330, you may even need to consider hypotonic fluid in this case, as opposed to DKA when we're reaching only for isotonic fluid. And like in DKA, you still do need to provide some insulin treatment to get the glucose within range. So that is generally the case until you get the glucose into the 250 to 300s range.
Well, thank you so much, Wendy, for going through this article and summarizing the management of such scary and important diseases. It's important to remember that the most common precipitants for DKA are insufficient insulin and infection. So we definitely need to make sure to look for that. Other individuals that are higher risk as well are pregnant individuals, patients with trauma, pancreatitis, or drug use, as well as those who are using the SGLT2 inhibitors, which may precipitate euglycemic DKA. So a normal glucose read should not exclude that diagnosis. However, typically the diagnosis is when somebody has a blood glucose level greater than 200, a pH below 7.3, bicarb less than 15, a gap more than 12, and positive urine or blood ketones. However, like we said, euglycemic DKA should definitely be a thought that we have, especially also not just the SGLT2 inhibitors, but also our patients who know something bad is happening, so they take some insulin immediately before showing up. And by the time we see them in the ED, their sugar has gotten better, but all the underlying issues with their fluids and electrolytes and acidosis have not. In these patients, as in all of the patients with DKA, we need to resuscitate them with volume or electrolytes, correct their hyperglycemia and acidemia, and recognize and treat the underlying cause. And the deficit in these patients, the adult patients, is around 7 liters. So that's a lot of fluids. It's important to avoid hypotonic solutions. However, using LR does lead to faster resolution of the high 9-gap metabolic acidosis when compared to normal saline. Obviously, in pediatric patients, we need to be more judicious with our fluid than adults. And we need to remember that we need to replete potassium even if the serum levels appear to be normal because our total body potassium is depleted. Insulin therapy is the definitive treatment by counteracting the issues happening with the glucagon and improving the acidosis. The initial bolus is 0.1 units per kilo, followed by infusion of another 0.1 unit per kilo per hour. And then we need to follow the glucose levels. If they don't fall by 10%, we need to evaluate our fluid resuscitation. When we get to the 200 level with the glucose, that's when we add a dextrose-containing fluid and keep that glucose level between 140 to 200 until the ketoacidosis has resolved. In pediatric patients, we don't give insulin boluses, and we continue the IV insulin until, again, the glucose has fixed itself, but also the bicarb is greater than 18 and the pH is greater than 7.3. It's important to remember that we should overlap the IV and subcutaneous insulin because of the short-acting nature of the IV insulin. If we don't do that, the DKA may recur. It's important to watch out for 2 important complications, such as cerebral edema and ARDS from fluid overload. HHS is slightly different because in that case, the issue is the altered mental status caused by the increased blood osmolarity rather than the acidosis itself. In here, the fluid resuscitation is the mainstay of treatment, and of course, we still do need to use insulin to correct the glucose levels. An important tip is that if the serum osmolarity is greater than 330 milliosmoles per liter, then we should give hypotonic fluids initially.
Thank you, Danya, for taking us through the great pearls from this article.
And moving on to our drug box this month, we have phenobarbital for alcohol withdrawal syndrome. And those of us who practiced during the really terrible benzo shortage a decade or so ago are likely to be quite familiar with using it because we had nothing else. Well, except for actual alcohol.
That's always the solution. But phenobarbital, it's a great option for alcohol withdrawal treatment as it does have a GABA agonist action. It can work synergistically with benzodiazepines. So if your approach is to utilize both, that is an option as well. But a lot of times people are favoring phenobarbital because of its long half-life, which lends itself to a self-tapering effect. It is also less addictive in the outpatient setting than Valium, but there is a dose-dependent respiratory depression. So same type of adverse effects that you have to monitor for. Another benefit in utilizing phenobarbital is maybe if it's additional mechanism on inhibiting glutamate neurotransmission. So both the GABA agonist effect, the glutamate inhibition makes it a really good option for alcohol withdrawal treatment. And so in terms of how to utilize it, you can give a 5 to 10 milligram per kilogram of ideal body weight dose, Or you can give 130 to 260 milligram dose every 20 to 30 minutes, titrated to effect with the goal of light sedation. Certainly, you're monitoring for hypotension, bradycardia, CNS depression, respiratory depression. And then another consideration would be for those patients who are chronically on phenobarbital, or maybe because of also concomitant comorbidities, they could be at higher risk for thrombocytopenia, megaloblastic anemia, and granulocytosis.
And last but not least, our Tox Box this month is paraquat toxicity, which is a herbicide that's used for reforestation and weed control, and it's exquisitely toxic. Now, intentional self-poisoning is just fatal because it causes widespread cellular necrosis with a particular tropism for the lungs, kidneys, and the GI tract. Basically, what happens is it reduces oxygen to superoxide, and super here is not a good thing because then it regenerates the paraquat, which is the redox cycle. So you have oxidative stress and then direct corrosion of the skin, mucous membranes, and GI tract. And it is rapidly absorbed by the GI tract. So any ingestion that's more than 1 to 2 grams, which is 5 to 10 mLs of the 20% formulation, is associated with severe toxicity. Patients come in with early GI manifestations, nausea, vomiting, diarrhea, abdominal pain, oral pain, as well as acute respiratory distress. If the person presents with a pained airway within 2 hours of the ingestion, go ahead and give them charcoal. However, if they're there up to 4 hours, you can try hemoperfusion or hemodialysis. And remember that permissive hypoxemia is actually a good thing because giving oxygen actually worsens the free radical production. And you can consider giving them N-acetylcysteine, desferoxamine, dexamethasone, acetylsalicylic acid, vitamin E. But basically, you're just trying your best in a pretty dire situation. If patients are presenting late or with large ingestions that are more than 10 grams, then palliation is really your only option with analgesia.
Scary indeed.
Well, thank you, Wendy, for taking the time to go through this issue with me. I learned a lot. Our dear listeners, we hope you enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication and our podcast always informative, often enlightening, and never boring.
Reach out to us on our social media. My handle on Instagram is at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And until next month,
bye-bye.